Nerve Conduction Study Part 6 Physiological Variability and Common Source of Error in Nerve Conduction Studies. Technical and Physiological Factors. Nerve conduction studies are very useful tests for evaluating peripheral nerve disorders, but the results can affect by many technical and physiological factors. Errors commonly occur because of problems in stimulation, recording, and interpretation. Understanding these pitfalls is important to avoid false diagnosis. Technical errors during stimulation or recording. Sometimes electrical stimulus is not strong enough, leading to submaximal stimulation and false low responses. Large stimulus artifacts, excessive electrical noise, or accidental stimulation of nearby nerve can also distort the recording. Incorrect placement of the recording or the reference electrode may produce inaccurate amplitudes or latencies. Error in measuring the distance between stimulation site can also lead to incorrect calculation of conduction velocity. Occasionally, responses may come from nearby muscles rather than the intended muscle, giving misleading results. Effect of temperature. Temperature has a major influence on nerve conduction. Cooling of a limb slows the propagation of nerve impulses. Conduction velocity decreases by about 2.4 meters per second, that is about 5% for every 1 degree drop in temperature between 38 degree to 29 degree Celsius. Colder nerves also produce higher Cmap and Snap amplitudes with prolonged response duration because sodium channel inactivation becomes slower. Therefore, if an NCS shows slower conduction velocity, prolonged distal latency, along with unusually high amplitudes, a cold limb should be suspected. To avoid this problem, skin temperature is measured using thermistor. Skin temperature correlates well with deep tissue temperature. If the skin temperature is below 33 degree, the limb is warmed using warm water or warming pack or hydrocollator. Sometimes correction factors are applied mathematically, but these are more reliable in healthy individuals rather than patients with neuropathy. Effect of age, newborns. Age significantly affects nerve conduction results. In newborns, myelination is incomplete, so conduction velocities are much slower than the adults. Full-term newborns have velocities approximately half of the adult values, while premature infants may have only one-third of normal adult values. Adult conduction values are usually reached by 3 to 5 years of age. During childhood, conduction velocities gradually increase in the upper limbs and slightly decrease in the lower limbs until adolescence. After the age of 50 years, conduction velocities slowly declines. By the age of 60 years, average conduction velocity is reduced by approximately 10%. Aging also reduces SNAP and CMAP amplitudes, especially sensory responses. SNAP amplitudes decline markedly after 60 years of age. In many healthy elderly individuals, lower limb sensory responses may become very small or even absent. Therefore, absent sural or other lower limb snap in older adults should not automatically be considered abnormal unless supported by other findings. Height and nerve length. Taller individuals generally have slower nerve conduction velocities because longer nerves conduct impulses very slowly. For example, conduction velocity in the tibial and the peroneal nerves of the legs are usually 7 to 10 meters per second slower than those in the median and ulnar nerve in the arms. Several factors contribute to the slowing, including reduction in axonal diameter, distal axonal tapering, shorter internodal distances in longer nerves. Conduction is also faster in proximal nerve segments compared to distal segments. In very tall individuals, a slight adjustment of normal values may be necessary, usually about 2 meters per second below the standard lower limit. Anomalous intervention. Certain anatomical variations can significantly affect NCS interpretation. Martin-Gruber anastomosis. Martin-Gruber anastomosis is a common anomaly where motor fiber crosses from median nerve to the ulnar nerve in the forearm. It occurs in about 15 to 20% of people and may be bilateral also. Because of this crossover, proximal ulnar nerve stimulus activates fewer fibers than the distal stimulation, producing an apparent drop in CMAP amplitude. This may falsely resemble a conduction block. The anomaly is confirmed if stimulation of the median nerve at the elbow produces a small response in ulnar innervated muscles such as abductor digiti minimi or first dorsal interosseous, while the wrist stimulation does not do it. In patients with carpal tunnel syndrome, this anomaly may falsely increase median forearm conduction velocities because different population of fibers are stimulated at wrist and elbow. Accessory deep peroneal nerve. Accessory deep peroneal nerves is present in approximately 20 to 30% of individuals. This anomalous nerve supply the extensor digitorum brevis muscle. During peroneal motor NCS, proximal stimulation may produce a larger CMAP than distal stimulation because some fibers travel outside the normal deep peroneal nerve pathway. Stimulation behind the lateral malleolus confirms the anomaly. Rarely, EDB may be entirely supplied by this accessory nerve, leading to preserved toe extension even in severe deep peroneal neuropathy. Prefixed and post-fixed brachial plexus. Prefixed brachial plexus and post-fixed brachial plexus are variations in the root origin of brachial plexus. Normally, plexus arise from C5 to T1 roots. In prefixed plexus, the root shift upwards, while in post-fixed plexus, they shift downwards. These variations may lead to incorrect localization of the cervical root lesions during clinical and electrophysiological evaluation. Rich canu anastomosis. Rich canu anastomosis, it's a connection between the recurrent motor branch of median nerve and the deep branch of ulnar nerve in the palm. This causes dual innervation of the intrinsic hand muscles such as abductor pollicis brevis and first dorsal interosseous. As a result, denervation changes may appear in muscles not expected for a particular nerve lesion. Similarly, some muscles may remain functional despite complete median and ulnar nerve injury. Temporal dispersion and phase cancellation. When a nerve is stimulated, the CMAP represents the combined activity of many muscle fibers. As the stimulation site moves farther away, the impulses traveling in the slower fibers arrive later than those that arrive faster. This phenomenon is called temporal dispersion. Temporal dispersion causes the CMAP duration to increase slightly when the amplitude and area decreases in size. This happens because positive and negative phases of different muscle fibers action potential will overlap and partially cancel each other, a process known as phase cancellation. SNAP are affected more. SNAPs affected more than CMAP because sensory fibers have a wider range of conduction velocities and sensory action potentials are shorter in duration. Even small timing differences between sensory fibers can produce significant phase cancellation and amplitude reduction. Inter-trial variability. NCS results may vary between different examinations. This is called inter-trial variability. The main cause include small difference in electrode placement, inaccurate distance measurement, and variability in measuring latency and amplitude. Amplitude measurements are particularly variable because even slight movement of electrode can change the recording response. Studies are generally more reproducible when performed by the same examiner because inter-examiner variability can be significant. Summary: physiological factors such as temperature, age, height, and anatomical variations can strongly influence neuroconduction study results. Technical errors in stimulation, recording, measurement may also produce misleading findings. Knowledge of these variables is essential for accurate interpretation of NCS and avoiding misdiagnosis of neuropathies or conduction blocks.